Thank you, Gene. Hello, everyone. Thank you for being here. I'm Tori Honegger. This is Alex Robinson. We are standing here reflecting on this morning's talk and thinking about how we had already been sort of anticipating some of how we wanted to frame this for folks and how we wanted to present this, especially through a lens that we felt worthy of this crowd. Thinking about the privilege that I hold, both in how I identify myself as a white male and how I appear to folks as someone who is in leadership at a CAPS, who has an advanced degree. I'm the clinical director at UCSB. I'm also very pleased to have Alex Robinson here, and aware of the lens of having two white folks here presenting this seemingly economical model, but that's not why we're presenting it. We're going to get into that. But I'm excited to have Alex Robinson here. She's relatively new to UCSB, and I am an opportunistic guy, and I saw expertise and talent, and I felt very strongly about offering single session, and we turned it around pretty quickly to offer it at UCSB. And Alex was prepared for the challenge, and then I felt strongly about advocating for it elsewhere on other campuses, because I think it makes us as a CAPS so accessible. And I'll let Alex introduce herself.
Yes, so I am a recent import from Canada, so I found that comment this morning rather humorous, because I have heard these things too. And before coming, I'm a postdoctoral fellow at UCSB. Before coming to UCSB, I was a clinician in Canada at a place called Eastside Family Center, and I'm going to talk to you more about that and explain how that is connected to the single session model. And so today, without further ado, I think we should just go over what we'll be talking about today. And
for folks just coming in, you want to crowd in, and there's a couple random chairs, standing room over here on the really nice wall. And is it better if I do, is this better for folks? Okay. And the clouds open up.
Okay, let's see.
Overview of what we're doing here today. We're going to learn about single session. We are going to give you some ideas on why you might consider having a single session model. Give you some background, which is considerable for the model, some attitudes and indications of what might be successful, structure and implementation, which is part of why I'm standing here, the research and what it's like implementing, especially as we're midway through implementing this at UCSB, and a couple case examples, and of course we want to leave time for questions, so we will get rolling.
Okay, so first question, when you hear, oh sorry, I don't have to show it now. When you hear single session therapy, what pops into your head? What do you think it is?
Low acuity client.
Pardon?
Low acuity client.
A low acuity client, okay. What else do you think of?
One visit.
One visit.
Case management.
Case management, okay.
Risk assessment.
Risk assessment.
You, sir, you had a...
Consultation and advice.
Consultation and advice. Anything else?
Problem solving.
Problem solving? What if I said it incorporates all of those things at different times and different aspects, but there are a lot of misconceptions about what single session therapy is, and we hope that we can clarify some of that, and I just have come up with a definition here that kind of captures it, but there's a lot more to it than just this. So it's a highly focused intervention conducted by professionals who use their existing skill sets and knowledge base to address the client's presenting concerns within one session without the assumption that there will be another session. We're going to talk about that more. There are a variety of single session service delivery models, but it's typically implemented as a highly structured, solution-focused, goal-oriented intervention. So why would we use single session therapy? See more clients?
Lack of resources.
Lack of resources?
Because one is the total number of sessions.
Who said that? One is the modal number of sessions. Thank you.
Gary?
Maybe at the end of the quarter or right before summer where you only have one session.
Brilliant, yeah.
It's more accessible to some of our students.
Maximize making a difference or impact.
Maximize your time making a difference or impact. Thank you.
In a short span.
Yeah, yeah. Anyone else? I think you captured a lot of it. So one of the things that I didn't hear anyone say, but it improves outcomes. I'm going to show you some of the research that has been conducted through the center that I was at over the last 27 years, and it's really encouraging. I love this one. We meet with clients at the time when they perceive they need it most. We're going to talk about that more as well. It helps prevent decompensation. Someone already said this, it's already the mode of treatment. There's an increased demand and often a decrease in resources, that was mentioned. It optimizes time for client and clinic, and it often reduces costs, and it works. So as a background, I'm going to tell you a little bit about where, from my understanding, the first single session walk-in therapy clinic was opened. It was at Eastside Family Center 27 years ago, which is in Calgary, Alberta, and that is where I worked prior to coming here. And it was developed as a grassroots movement by community leaders who wanted to address underserved populations within that city. Calgary is a very multicultural city. We have a tremendously high rate of immigration, lots of refugees, people from all over the world. They say that every known language is probably spoken in Calgary, and there are a lot of barriers to accessing services. Language barriers, there's barriers about mental health, there's stigma around services, Alberta Health, we offered it free, so it removed all of the cost barriers. So there's all sorts of things that it was trying to address, and it was they had no idea if this would work or not. And over the past 27 years, they've been very, very mindful about how they have introduced it, how they've offered it, and I think it's appropriate to present it at a symposium where that we're focusing on a multicultural lens, because that was the lens through which they were trying to develop this model. So they were very deliberate in treating each session as a whole therapy, and they focused on the client's theory of change. Initially, it was developed on the 5-part Milan model. Well, not initially, actually. They tried many different things, but eventually they came up with adapting the 5-part Milan model with a pre-session, where there's a brief consultation, a session, an intersession, an intervention delivery, and then a post-session debrief. And within the pre-session and the consultation, there was multidisciplinary consulting teams, so psychologists, social workers, marriage and family therapists, psychiatric nurses, psychiatrists, and practicum students and interns. The therapeutic framework, again, under a multicultural lens that recognized the dominant culture determines the norm. The therapist's goal was to uncover and respect cultural and experiential differences, including those based on long-term or recent immigration and refugee status. This was one of our preliminary questions in intake. It was based on a systemic approach, postmodern, social constructivist, and a brief model therapy framework. It's very much strengths-based, solution-focused therapy. It integrates family therapy, narrative therapy, and cognitive behavioral therapy. And we believe that no one therapeutic approach will fit every client. And we also very strongly believe in using the client's resources and strengths to assist them in solving their problems. And it's a very transferable model, as we're learning. We're also learning at UCSB. It's been adapted to counseling centers in South Melbourne. They have a setup similar to the CAPS, where they have they've integrated the single session therapy model as one of their options, and that's what we're working on right now. There's 2 hospitals in Calgary that have incorporated the model to make a walk-in service available in their emergency care. Arnie Slive, who was a former director at Eastside Family Center when it was first being developed, has opened a single session center at Our Lady of Lake University in San Antonio, Texas. Apparently, there are quite a few people who have been to some of his workshops that have been offered through UCs. Michael Hoyt's a California man. He restructured quite a bit of the mental health services within Kaiser in the San Francisco area. I've worked with John Miller in teaching this method in Singapore and Cambodia. There's other places in Canada, Australia, Mexico, US, and UK that are finding this to be a really effective model to help meet the ongoing demands. Okay, so is walk-in counseling model more effective than the traditional model? That's a big question.
Provocative.
And provocative. So quite recently, actually this last year, there was a really interesting study that came out of Kingston where they offered 524 individuals at a community clinic the option of either using a single session a therapy intervention or the traditional therapy intervention, and then they compared the outcomes at 4 weeks and 10 weeks. Basically what they found is that participants who attended the walk-in counseling clinic improved faster and were reporting outcomes at subclinical levels within 4 weeks of having that session, whereas those who engaged in the traditional treatment model also improved and came to some subclinical levels. On average, it took 10 weeks. So yeah, they both work, but one just takes longer.
Can I clarify?
Yeah.
They got to choose.
They got to choose, and we're really big onto that. We don't tell anyone, all we have is a single session, or it's always optional. Just one of the things they can choose from. So, some of the attitudes and indications when you're considering whether or not you would embrace this model, you'd want to learn this model, you'd want to implement this model, are some important considerations. Are that we should view each session as a whole, potentially complete session in itself. We should expect change. We should always play to the client's strengths. Recognize that all you have is now, and that the main force of life is change, and you don't have to know it all to be effective, and you don't have to rush. That's one of the things people always say, how do you do all this in an hour or an hour and a half? It's amazing. When you have a really structured kind of idea of how to move along the session, it's amazing how much happens without feeling rushed. Recognize that a small step can make a big difference. And recognize that it's practical and ethical to provide timely services. So now I'm going to turn it over to Terry.
So we've toyed with the idea of calling this the intensive focused therapy intervention. And one of the ways that I talk to students about it is that this will be a deep dive, a very intentional dive into what you're struggling with. And that's how I kind of frame it if I'm engaging someone on this is a possibility for them. While at CAPS, one of the things that I struggled with and then took this to leadership team and sometimes to staff members and had open discussion on are some key factors when I was thinking about how do we operationalize this. We have someone who's got tons of experience and has a lot of expertise in this area, but we can't expect her to do all the single sessions that we'd like to offer, so we can't really offer it on a large scale. She's a postdoc, but why not have a postdoc trained staff in a new modality? I got to thinking about that. I'm like, there's no real reason that licensed people can't actually learn from a trainee. In fact, that's why I'm in a college counseling center that has an APA training program. So we started working on that one, and we trained one of our triage folks, and now we have a number of psychologists that are all learning together as we move forward with this new modality. And so we are rolling this out somewhat slowly. So some of the questions or the key factors that I considered in implementing this are this whole idea of having a triage. This is a disposition of a triage, or it's something that a student could select off of a menu. So they're on the website or they're at the front desk wondering what services, and they want to know what to ask for. And our students do look for the language and they want to ask for things, correct? So we've adopted a triage model. We're in transition to what we're actually calling that currently brief assessment, but we're looking at initial consultation as the phrasing we're going to use in the next school year. And we believe that really captures that initial interaction. Sometimes it's brief, sometimes it's not. So initial consultation is much better. And this is one thing that's offered in that context. On the larger national stage, when you compare other counseling centers across the country, everyone is talking about stepped care. And stepped care, does this ring a bell for anybody? Okay, I got one person. Thanks, Gary. Step care and Step Care 2.0, and what I'm going to be pushing forward is collaborative care. So Gary, I'm going to rebrand it as collaborative care. But Step Care is actually a thing, and there's a lot of research about this, but it's really just a menu of options, both clinical and non-clinical, and they're presented to students in an intentional way. And so rather than this medicalized triage version that might be a little off-putting to some students and staff, I want to introduce a warm, friendly conversation around what it means to get your needs met in our clinic environment or outside our clinic environment or somewhere else on campus is more appropriate. So to that end, an initial conversation seems quite appropriate, an initial consultation. And stepping away from this idea that we're going to process through as many students as quickly as possible. That might be true, but I wanted to have the warmth and engagement and be culturally aspiring to be meeting people where they're at and what they're bringing in. I don't want to make a one-size-fits-all model. And so I had to think about that, and so we did land on, yes, it's we have a triage system, we're going to use it in triage system. Other places, I believe Oregon State and Appalachian, and one other place actually, it's just a menu item. Someone can come in and ask for it. You go big or small. I decided that we should go small because we had one person that was fully trained and capable of it. And I wanted to see how the students would react. I wanted to see how the staff would react. We're pushing a few boundaries here in terms of offering and not wanting to be seen as offering less or trying to be economical with our services. I wanted to have it be an option that really felt like something the student was getting. And so to that end, we started small and we've gotten amazing results, which we'll talk about in a moment. But if you are bigger, more organized, and have more expertise on staff, you could go for the big launch. Our big launch is not happening until fall, but how we've started small is very intentional, offering up with our triage team and being very specific about who we're referring for those single sessions. And that intentionality has really helped. How you frame this for the students, I have alluded to, is very important. We want folks that are ready to do work. When they come in and say, I just don't know what I want, and even after a few minutes of conversation, they still don't know what they want, single session might not be the best place for them. But contrary to what some people might believe, higher acuity is something that the single session can tolerate. And I've thrown a couple zingers at Alex. Single session as a normal solution focused, or it's the default. A lot of times it's just one session, and you can do that. And some of the folks that I spoke to at the Clinical Directors Conference that have implemented single session went with a very generic, just here's a single session. And it looks like a lot of other sessions, but it's just one. We've chosen an empirically validated, much more intentional approach that has an actual anatomy to it, and we're going to go over that. The deficit focus versus exploring what a lot of the more newer theory is calling capacities, another way of saying strength-based. So a lot of our, everyone's on CCAPs, and we have all these different things that really focus on what's wrong, what's wrong, what's wrong. But especially if you're not part of the majority, and you've heard how you don't fit in, or you're the only one, or what's wrong with you, in different areas of your life as you've grown up as the other, and you come in and it's all focused on negatives and pathology, as a lot of our questionnaires are, what's wrong with you? This model attempts to steer that dialogue, and especially as many of our institutions are focused on the white majority, I want to promote modalities that actually focus on strength-based, or what they're calling in the literature a lot, the capacities of the student in front of you. So we have chosen to steer away from our deficit focus, even though all our paperwork is immersed in that. And I really just invite all of you to consider what she has already mentioned, that this is the potential, every session, every meeting with a student has the potential to be the only one, those initial meetings. So how do you really use that with intention? Gary?
Do you triage in person or phone or both?
Thanks. Good clarification question. We do in-person triage. We would accommodate a student if they wanted to do phone, but we encourage them to walk in, mostly unscheduled, sometimes scheduled. Again, flexible, meeting students where they're at.
And I just want to add to something that Turi was addressing already, the tendency to pathologize in our profession and how different this is. When we, at Eastside, when new community therapists or providers or psychiatrists would come in, often volunteer to come in, a lot of our providers were volunteer, they would have that tendency in the consult to say, oh, I think this woman has borderline or something, like they would be very just quick to try to label and name and focus on the problem, and it would take a little bit of reworking and working with that provider to teach them that that's not helpful, that we're focusing on what the client came in for, what their needs are, what their goals are, and we're not interested in diagnosing or pathologizing. We just really want to empower them to see the change that they really want in their life. So, and help them, we often would say, find out where they're stuck and help them get unstuck.
Probably confusion, but when you talk about in-person triage as a single session, are you saying that the single session is folded into a triage, or you refer to single session from triage if that's what you want?
The latter. We refer to single sessions. So just for everyone, the question was about order of events. We do have a brief an initial consult. And then this is one of the options we're referring to. We are going to talk about that, but generally speaking, we will not schedule that more than 7 days out. Emphasis on the timeliness. But there is that initial, they walk in, they're there for the triage or the initial consultation.
Okay, so this is where it gets really fun. Here are the nuts and bolts of how to offer single session, the single session anatomy, as Turi puts it. And this has been slightly tweaked so that it works in the CAP system, but the general flow has been developed over many years. So the brief assessment, like Victoria was already talking about, first of all, we have the brief assessment. And if the student chooses that they would like to opt for a single session intervention, then we schedule that within 7 days, just like Turi had mentioned. When the student, and actually we've incorporated a little flyer that we give the student that if they choose the single session option, then it also goes over the structure of the single session so that it doesn't feel surprising or strange or anything. And we'll even ask them again, does this sound like something you want, or does it sound like it would fit for what you're looking for? And so they have a few different points where they can really decide if that's something that fits for them. When the student does show up for their appointment, they're given some additional, so they do the CCAPS and the SIF, but then they're given some additional paperwork. And I have a couple slides down that show you that paperwork. And again, these were questions, really solution-focused, goal-oriented, strength-based questions that we developed over the course of the 25 years or so that Eastside's been offering this model of treatment. And they've really honed in on what are the most helpful problem-solving questions that we can ask clients coming in to help move them forward or get them unstuck or address their presenting concerns. And what we found, there's also been years and years of longitudinal research on this, and what we found, there's certain questions that based on how the client answers, it's quite predictive of how much they'll experience a decrease in distress, and I'll show you some slides on that after. So they do all this extra paperwork. It only takes them about 5 to 10 minutes extra, but it's really helpful. And then that's handed into the front desk. Then we go, if there's only one clinician available doing the initial part of the session, then they just review the paperwork, but oftentimes their colleagues are around, and so we would consult saying, oh, this is high acuity, doesn't look like they have many supports, that they have a lot of internal strengths, like kind of really briefly case conceptualize which direction we might want to go in the session. And then the student comes back, we invite them back for the session, and I always start off the session by explaining again what it's going to look like. So I tell them that, well, we're going to talk for about 30 minutes about what brings you here today. I really want to understand what your goals are and what would be most helpful. And then I'm going to take 10 minutes and go consult with our team, and you can use that time to reflect or just to have a break. And then I'm going to come back and share with you what the team's ideas were based on what you were wanting, and hopefully some of those ideas will fit for you. And then ask if they have any more questions. Sometimes I elaborate more if they seem to have more questions, or if they seem nervous, then I'll make sure that they're comfortable. Sometimes I'll ask who's on the team, and I'll be like, oh, it's Turi, and you might have met him with a friend, or whatever. And I sometimes will ask if they're even comfortable with the consult. At Eastside, we also had one-way mirrors, and sometimes people wouldn't like that. We had reflective teams. Sometimes people would really want that. Sometimes they would rather not. So there's always this sort of agency. We're always trying to empower the client, make sure it was client-based, strength-based.
Just in addition, the consultative component is actually what we've found over the last 50, 60 some single sessions is who's on the consultation team is actually a really important question for some folks. And so we've just sort of incorporated into being more transparent about what that means. We've even toyed with the idea of what would it mean for them to sit in on the consultation, but we haven't gotten that far yet. So, but that transparency is really important for that trusting piece. So.
Yeah, and actually we would often do that where the client could sit with us while we consulted, or they could be on the other side of the wall here, and we'd flip places so that they could really, it was really powerful. Sorry, you have a question?
I apologize if I missed this part, but how many people do you have on staff? How many therapists?
In our clinic, we have 25, or it fluctuates. We have a number of therapists and trainees. However, this consultation team sometimes is as thin as she hinted at. Sometimes I'm it, and as an administrator, I'm just responding to crises and things, and there's little blocks on my schedule whenever a single session's happening, smack dab in the middle of that single session. So you're guaranteed at least an audience of one of us managers or two of us. But with our triage team, all being in on that consultation, and them being in and out of their triage appointments pretty quickly, we've been able to get small, 2-3 person consultation teams together pretty quickly. And my difficulty as the scheduler for this fall is how do we expand this now to not just 1 or 2, because now we have 3 people doing it. How do I get now a team of 7 to 10 people doing single sessions at different times of the day and guarantee that consultative component is there without negatively impacting my fragile schedule? So we'll get back to you on that one. That'll be version 2.0 this time.
Still working on that. Okay, so that does lead us nicely to what does that consultation look like? It did go up. So what happens is the client leaves the room, goes to the waiting area, or they can stay in the room if they feel more comfortable, whatever. We've actually been toying with the idea of even offering refreshments and stuff so they could have a nice space to reflect. But anyway, so while they're chilling, we are working really, really hard. This is, when I say that you don't have to rush, you don't have to rush in the session, but during the consultation, it almost feels like manic or something. It's like you have about 3 minutes to present, maybe 5 minutes to present the case. So you do kind of like the headliners of the case from what you've been able to gather. You start out with the goal. What is their goal? Their goal is to reduce stress, to manage panic attacks, to whatever it is. And then you talk, and then you give some background and some history of why this is problematic for them, what things they've tried, what's worked, what hasn't worked. All those things are part of the interview in the first 30 minutes, and so you're trying to really, really hone in and capture what's going to be most helpful. And then the team, first thing they do, and this is going to sound a little strange perhaps, because it's not what we typically do, is, and I remember one of my supervisors when I was first learning this would say, what did you like about the person in the room? Oh, that's a neat way to start before anything else. First thing we do is talk about what we appreciated or their strengths or what we noted. And then that's actually the first thing we bring back to the client is, wow, we just noticed how much courage it must have taken for you to come in today based on what you told me, or how hard it was for you to walk through these doors, and we just want to say you're so courageous. Or we just really noticed how, you know, how kind and giving you are, whatever, just depending on what stood out most as their strengths. So we often start with commendations and validations, and then we go on to the team interventions. So after we kind of establish that, then okay, what's going to be most helpful to the student? What are the resources here on campus? What are their internal resources? Do they need a referral? Do we have any really good handouts? Are there any really awesome apps that can help them right now? Do they need more information? Do we go through some mindfulness work? And so there's all these different options, and the team brings in their own kind of lens, and so you get some really cool ideas. I've learned so much from the consulting teams because I'm not aware of all the resources available, or all of the little interventions that other people use that are so effective, and they can quickly explain, well, this is, you know, an adaptation of a CBT technique, and it might be really helpful, or this is a handout that I made for my clients, and you might find this really fits well for your client right now. So that's what we do. We have 10, 15 minutes to get all that pulled together. So it's really intense.
I just want to emphasize that this consultative component, while a little challenging logistically and might seem a resource-rich thing to do, if you leverage the persons on your team, like our triage folks and the leadership, you actually can cobble together folks, like I said. Now, the richness comes in this, you're sitting with this person, you're sort of embroiled as they are in what's going on with them. But when you pull the highlights out, and particularly the capacities, the strengths of that student, and you're highlighting these and you're reflecting on this with your colleagues, something really cool happens with the ideas, that they don't become your usual. This is super effective when you're doing it with trainees that are relatively new or new staff who are, like Alex, trying to learn all our resources. So it has a teaching component to it for the folks that work there. It has a teamwork aspect when a lot of our work is done behind a closed door with someone that we may or may not see again. But our colleagues aren't going to know the wonderful work that we did. In this way, this consultative piece is really invigorating for the work. And it's always really annoying when I'm in my manager's office and I'm agonizing over something on my computer or fielding a call, and I'm listening to the consultation thing that I'm missing out on in the room next door, and they're all intensely engaged in conversation and laughing and this and that and everything else, and having a grand old time at work, and the clinical director is like, I wish they'd get back to work and finish up with that student so that they can see the next one. But that's my internal dialogue, and my external dialogue says to them as they walk by my open door, hey, nice work, it sounds like you're all really productive in there. And I'm joking a little bit when I say all that, but not that much. It is really a cool thing to see, and it sometimes seems like they're just having a great time consulting.
It is exciting, and it's intensely meaningful when you start to see the change happen and the students' feedback, which we're going to talk about. Just to quickly go over the interventions that we often use, like I said, commendations, validation, doing tasks. Reframing, we often provide handouts, split opinions. I love using the team for split opinions. Has anyone ever used split opinions? So one part of the team says...
It's a Greek chorus. It's a Greek chorus.
Right.
We've caught that copy.
Yeah. So yeah, one part of the team says, you should just keep doing exactly what you're doing. And they're like, what? And the other team said, this change, recognize this is going to be really hard, but A, B, and C might be more helpful. I don't know. And so you're kind of like letting them make the decision, but you're kind of using the opposing ideas to create a dissonance to kind of help them get unstuck and help them see the problem differently. So it's a fun one to use, but you should read up on that first. Psychoeducation, often, especially with anxiety, and certain presentations of depression, psychoeducation is very helpful. And then, of course, referrals. So who to refer? This is something that we've really been talking about a lot with the triage team. Trey, you should address.
Absolutely.
And
Think about being that student who has been left by this therapist that just spent 30 minutes with you. They've now left for 10 minutes. Now they're coming back in the room. But think about how it might feel, the amount of validation, the amount of intention that went into this plan. And as you were sharing some of the basics here, I was reflecting on one of the most intense students that I had referred to Alex a couple months ago. And the consultation portion of that was pretty intense because there were some risk factors involved. And so we had to do some safety planning on top of logistics, academic stuff, so we're referring him to other departments on campus. It was pretty, so we started typing it up and we came up with a really tight plan. This student hadn't been heard like that in his experience as someone who had immigrated to the country for his education, as someone who was a young man of color, as someone who was a first-generation college student. He had not been listened to and then thoughtfully planned for in that way. It was pretty moving, and that very same student really struggled even to engage for that session. As I recall, he had to run off to go do something for a professor and came back an hour and a half later for the intervention portion. So you can imagine how challenging this is with the schedule, but that was someone that might have gone to the hospital. And indeed, we were recommending hospitalization in emergencies a couple days prior. He wound up not going. But he came in for this single session because it's all he would say yes to. And the dramatic difference was just astounding. And the entree to him actually considering medication for the first time in his life after struggling with depression for many years. A little anecdote.
And Terry doesn't know this, but I just got an email from him 3 days ago, and he said I aced all my courses. He was about to drop out or kill himself, and he really turned around.
I didn't know that.
Yeah.
That's fantastic. Thank you. Thank you.
Yeah.
Sorry, I'm feeling a little fuzzy in front of all. So who to refer? And so low acuity might seem like a thing that you want to be referring to this, but I actually challenge you to push that one a little bit but not too much. And especially depending on the experience of your single session people. Students who are highly motivated for change and they come in saying, I want to do something, I just don't know what to do. If you hear that in what they're saying, that's a good one. If there seems to be some clear identified goal or a set of goals or some direction,
That's huge.
That's huge. And a single session can be used to sharpen and focus that direction. Situational crises are great. Panic disorder, especially with the psychoeducative component to working with that is great. I have found, I don't see it on this list, but getting folks who are really ambivalent about medication to really seriously consider medication, the single session has worked for that. And you can read the long list here, but and I'm curious if you, because you have more experience with this than I do, some that might not seem as intuitive, like autism spectrum, personality disorders. Like, what does that look like?
Well, I actually love getting personality disorders for single sessions because you don't end up getting necessarily that push-pull. They're just there, you're all there to help them, you're coming up with a intervention and they're feeling hugely supported and you don't have to deal with that whole rejection thing. So actually it can be appropriate, it can be helpful, and then so by the way, single session doesn't mean you only get one session. That's why we're toying with like maybe changing the name of it or presenting it differently. But they can come back. It doesn't mean that like they only can come once and then they can never have another session again and it cuts them off from other services. So they can continue to receive services, but kind of on their terms and their when they see that they need it most.
We don't emphasize that part.
No,
The same.
no, we don't. But it's it's something that we want to. One of the things that students will ask is, does this mean I can never come to CAPS again? No, it just means that you really wanted some timely help with a certain problem or situation that you're stuck in. So,
Alex, of the 80-some almost 90 single sessions that have been completed in our clinic, how many have come back in?
maybe 4. Yeah. So they mostly are highly satisfied. I'm going to give you some of the data that we've been collecting.
But I think you should underline that.
So, yeah.
90 and maybe 4. 90
Students.
individuals came in for a single session over the course and have seen Alex or Molly or Grace, and she's done the bulk of them, and only 4 of those have returned. You might think that this is an invitation for a revolving door, especially frequent flyers or people who just show up in crisis. But because of the intentionality and that this was something that was selected during the initial consultation, and that there was some prep work asked of the student before coming in. That is why we're getting those numbers, I believe,
Yeah.
is because we're prepping the student for it. They come in, they utilize the service properly, and we don't see them again, generally speaking.
Right. Okay. It's also really, it's actually an excellent intervention for high acuity. That's not intuitive for some, but all the research that we've collected and other sites have collected that show that the higher the acuity, the more helpful they find the intervention and the greater the experience of decrease in distress. And I'll show you the measure that we use just for pre and post at this time.
Do we want to speak to less appropriate or bad?
Oh, less appropriate, yeah. So yeah, if someone's looking for ongoing therapeutic support from the same provider, it's obviously not an appropriate referral. And there are some students who know exactly what they're looking for, and it's not going to fit at all. Students who they're ambivalent, they just have no idea why they're there, they don't have a goal. That's not going to be what can we do? It's not going to be very helpful, and those are frustrating for the clinician as well. It's really tough when there's a couples issue, like a relationship issue, but only one person's coming in. That's really tough to deal with, so we don't encourage that. Individual who's seeking an assessment, obviously we're not doing assessments in that time. And someone who needs ongoing monitoring, like bipolar, and of course some of the personality disorders. It's just, it's hit and miss with those. They can be really great. Not everyone likes working with that demographic. Okay. I'm going to quickly just let you know a little bit about the additional measures and surveys. So prior to, after they fill out the CCAPS and the CIF, like I said, there's some additional paperwork. And I'm just going to go to it right now. We have a pre-session form. I can't even read that. Can you guys? Okay. So we're identifying, first of all, we want to know what brings them in today, what their level of distress is, and get them to self-rate their current level of distress. This is really important. We want to know what they've tried. We don't want to do the same things over again that they've already, or suggest the same things they've tried that haven't been helpful. We just really believe that they know themselves best. And we want to know what their strengths are, so we can build from strengths. What services they access, because we could either reconnect, or if we see there's this obvious service like drug and alcohol program and they haven't accessed it, but that's really what they're in for, like they're coming for help with that, then obviously that's something we can use to guide our intervention. And then previous counseling. What is most predictive of outcomes we found over some pretty interesting statistical analysis and research over the years is how they answer questions 7 and 8. So I can't even read it, but please help us understand what you would like from today's session. So information about, a decision about, help in understanding, and then the last question, for some people, a single session with a counselor is sufficient to take action. Hopefully tell you things are going in the right direction. If they actually answer this question and have a little bit of detail or clarity on that question, it predicts when we've done outcome measures at 3 months, 6 months, and a year, if they answer that question, their level of distress decreased the most and they've been able to sustain the changes the longest. So that's a really interesting question to attend to. And when I see that someone's taken some time and thought with that question, I get really excited. So, and then we do a post-session feedback. This is my favorite, and I think it's becoming everyone's favorite who's on the consulting teams. Even, Tori, I think you enjoy this too.
Yeah.
So we have the post-session feedback. So at the end of the session, I just ask if they wouldn't mind taking a couple minutes to give us some feedback. We want to know what we're doing well, but also what we could improve upon. And so they just rate this according to these questions. And was there anything missing for you from today's session? So we didn't actually, the first few sessions we rolled out, we weren't using the pre and post. Well, I was using the pre, but I wasn't doing the post session feedback at first. I don't know what I was, anyway. So, but of the last 70 sessions, we've been using the post session feedback, and I have some of the outcomes from that. we've only had two say, was there anything missing from today's session? One said, I'd like to be able to see this therapist again, which is possible, right? They just didn't understand that, so we needed to clarify. And another said, I wish I had more time. And so that's a reality that it is a limited service. So we were about an hour and a half with that client because our intercession took a little longer. And then what was most helpful about today's visit, there was just a ton of feedback on that. The main thing that students are saying is that it was so helpful to be actually given a plan based on what I came in for. So that's kind of the number one thing that's showing up. I've done a little bit of thematic analysis to see some of this, and there's also just having somebody really listen to me is huge. Someone helping me see things differently, that's another one. But they have almost all the clients will take a few moments and fill out that one. And then, how would you rate your level of distress? And so we do this so I already gave them the pre. This is Miller's pre and post distress rating scale. You can pull it off the internet. And then how would you rate your level of distress post? And even if they don't identify that their level of distress they don't strongly agree that their level of distress came down in the questions above, their level of distress almost inevitably comes down, but it's typically in half. So I'm going to just show you some of the data. This is Eastside data collected. This is from 2015, I believe. This was just an analysis of 539 clients that had come through. So they're
Now, Alex, you have more recent data. We couldn't get the numbers for 2019, a much larger sample, but interestingly, they said similar story.
Yeah. Actually, it looks like with our smaller end, we're doing really well with that pre and post. But anyway, so you'll see there's a pre-session distress, post-session distress decrease that's significant.
I'm curious on how this compares to traditional therapy, after first session traditional therapy.
Yeah, you know what? I don't know if I can answer that question. It would be a really interesting comparison. You know who could answer that? Because have you heard of John Miller's Clinical Center for Excellence? Or Center for Clinical Excellence, sorry. I know that he does a lot of that. He collects a lot of that data, so we could probably compare with that. Yeah.
And this data, what is the mean age of the people that you see today? It's a community mental health?
Yeah, it was community mental health, so it was the whole spectrum but for giving for consenting to any research, they have to be 18 or over. But so it was like 18 to, it could be 70, but most of the demographic was about 18 to 40-ish. That tended to be our client base. So I'm going to show you, it'll be more interesting, I hope, for you to see the CAPS pre and post. I think I did this analysis when we were at 62 or something. So presenting concern pre-level of distress was about 6.7, we averaged it out, and then post-session was about 3.4. So you can see that's pretty much in half. So that was encouraging data.
The anecdotal reports also, if there's a space for them to kind of reflect on their experience, the anecdotal reports, generally speaking, are super positive.
Yeah. Okay. So how to refer? Do you want to do that?
I'll start. You can. You'll fill in the blanks I'm going to leave behind.
Okay.
I've said this a few times, but in that initial consultation or brief assessment, we're introducing options. We've already kind of assessed their needs. We're not going to introduce this as an option if we don't feel like it's appropriate. So there's already some sense if we're offering this that it might fit with what's going on for the student. And as I believe it was Gary who pointed this out, at the end of the quarter, when there's very little left on the schedule as far as proper intakes and things of that nature, this can be just what a student needed. And the idea of calling it a single session might be a little off-putting because initially they're just thinking, okay, I can't go back, it's just this one time. Is this a contract? Am I signing it in blood? But the reality is we're a very flexible system and we really try and help students be seen quickly. So there's the timeliness factor, and we do say that out loud. We help them advocate for their own needs and we educate them about what's available. And so that's a conversation that happens no matter what we're really recommending, but it's particularly important for this. And then you can see that we have several prompts here. Many times people find that one, very focused session, or what I often refer to as a deep dive into what's going on, is enough to get them moving in the right direction. It is a very structured session that will focus on your goals and offer ideas and strategies based on the specific needs that you talk about. And they really like that this is scheduled in 7 days or less. And sometimes it's that afternoon they're getting scheduled because there's an open single session. Oftentimes it's within a day or two. And the timeliness is really part of this whole game. And it really, really helps with the student because on our campus, students are presenting for that initial consultation, usually without an appointment. They walk in and there's one of our triage folks, we call them clinical coordinators, and they fill out their stuff and they're seen anywhere from 15 minutes to 45 minutes later, and it's in person. So,
Can I just speak
yeah,
to that
add
some
to-
days? Oh, sorry. So we try to just have it on my schedule, just open, single sessions available, you know, throughout that month or whatever, and the front desk was just booking it up, and it was filling up a month in advance. And what was interesting, there was cancellations. If it was more than, we just found that if it's within 7 days, that they'll come to the services, but if not, it was more likely there'd be a cancellation or the situation, or they'd be compensated or something, you know, not ideal would happen. So that was, we're gonna really stick to that from here on out. And you're probably curious about who was chosen to opt into it, just in terms of the diversity of the students who are opting in. So it looks like representative of the students on our campus. I think we have 33% white Caucasian, and that's about the number that's opting into the service. We have 23% Chicanx and it should be Latinx. We have another 8.45, and if you add, it's really weird, but if you add those two numbers together, it's 32.39, so it's kind of the same for those two demographics. And then you can just look down the list and see that the Chinese American are also choosing to utilize the service, quite representative, a little underrepresented actually of our campus in general, and Terry, you probably want to speak to that more.
Just for a little context, at our campus, at UCSB campus, I think we just ran the numbers on this. 64% of the students utilizing CAP services identify as students of color, and that's collapsing all categories. So, and which maps onto the campus population pretty well. And so, and then even with this smaller sample size, because we're really just dealing with 3 clinicians work here, spread over a little bit more than a quarter, we've seen very similar statistics popping up. So we're encouraged that we're not necessarily in the referral process favoring anyone in particular or ruling anyone in particular out. And so we are keeping an eye on this. I think it'll be, as we explore our biases as a staff and see how it maps on to our service delivery, it's something that we're thinking about, and we're running numbers on it, and we're wanting to check ourselves. So, but at least initially encouraging data.
And I don't know if this is too much of a jump, but in the feedback, regardless of ethnicity, there's still, ethnicity or race, there's still this really positive response from the students. So we're just seeing that right across the board. It's helpful. I already addressed this. What if I do more than one session is a question that students might ask. One of the things they'll ask is, can I see the therapist more than once? And for single session, we're not encouraging that. We want them to kind of align with the service and not the therapist. So, because then they might end up trying to use it as just a way of getting more access, quicker access for ongoing therapy. So we just don't want to encourage that. Something to think about.
In terms of operationalizing this, that was a real sticky point for myself because for years I've thought, you know, you want to minimize the number of providers that a student, especially a student who's in need, is seeing. It's confusing if they meet one person, they meet another person and another person. And so this model sort of pushes against that a little bit. So I'm still working out in my head like how I really want to operationalize that for fall. I do not want to do it if I only have 3 people doing single sessions because then they're going to get overburdened with requests in addition to all the other referrals they get, correct? But if I have a whole team, which I expect to, by fall have 7 to 10 people trained in this model, then we might have a little bit more wiggle room for those students that want to stick with their, so we're gonna, that's a wait and see on that. Question? Yes, Julie.
Around what percentage of these single sessions result in either the clinician, the consult group, or the student saying, I like more of this? Like that, how much? How often
I think we said earlier, of the 90, only 4 have bounced back. So,
and even the ones where you're like, oh, go try to sit out for a while and then come back.
Yes, so we might see that in the fall. I don't, that's fine. But it does certainly, it reduces, having, well, 3 you can address this, but having that whole formal intake and then your session and then scheduling throughout, if they feel like that's helpful enough for them for that time and they want to come back because it was helpful. This is something we saw at Eastside quite a bit. Like we would see someone maybe even like 2 weeks in a row, a family in crisis or something. And then we would not see them again for years, and then they would show up with a new crisis or a new reason for coming to services. So, yeah. So I hope to see them again if it would be helpful. But hopefully they get enough to work on from that session that they don't come back. I know we're down to 10 minutes, so I want to just go over what this might really look like. So a case example, you get, in the intake forms, you get a student who's reporting racing thoughts, trouble sleeping, poor concentration, is being, is isolating, is worried that something terrible might happen, so obviously high scores for anxiety. So the session would start with the explanation of the services, like I went over already, and of the model, which really is when we say we're going to brainstorm together. I often say, I think 2 heads are often better than one. We're really going to help you work on this and try to come up with ideas to address your goals. It's supposed to instill hope. That's the theoretical underpinning of that. And that kind of sets the framework for the whole session. So then you look at those intake forms with it. So you look at it before, then with the student, you say, okay, I see that you've got these great strengths, you've tried this hasn't been helpful, so we won't even go there. And so you just kind of look through their forms and really address the things, especially those last couple points, what would tell you that things are headed in the right direction. And then you work on that through the whole session. So yeah, there's your goal. So I often will ask, what's the worst it's ever been? And then I look for exceptions. When have you been able to have this experience, let's say, of anxiety, and been able to, manage it, or still been able to go out to that party, or whatever it is that they're functionally impaired in, I guess. So anyway, we get all of that, try to find the exceptions. I often will use scaling questions, and just to really understand how it's presenting in their life. Again, looking at their current coping strategies, what have they used? Some people say, I tried the breathing, it just made it way worse. So we explore that a little bit, or we just move on to something that might be more helpful. And using a lot of motivational interviewing. We'll review other systems available and supports available for the intervention, to inform the intervention. And then we always incorporate a risk assessment. Of course, some students that are coming in and they're saying, I need a session now, I need an intense session right now, there's often risk involved. So we get a lot of higher acuity, obviously, and so sometimes our intervention is safety planning and referrals. And then we offer the intervention. Again, like I explained, we would include the accommodations, their coping strategies that we could introduce, psychoeducation, sleep hygiene handouts, if they were saying they couldn't sleep, homework sometimes we'll externalize, we might externalize anxiety, and when anxiety shows up, this is some things that you might find helpful, and again, with referrals. And then the session is really, how you end is really simple. I hope that you find some of these suggestions helpful, and I hope that you find some of this helpful. And we don't usually say, come back for more support if this wasn't enough, or if you didn't need it. You just want to end it really confident and calm. And that's the end of the session, and it seems to be going really well. I don't think we're going to have time for a little breakout, but do you want to add anything to that?
No, I think you articulated that sort of what it actually looks like pretty well.
I'm gonna just skip that.
Do we want to move towards questions?
Yeah.
We've talked
That would be
about
great.
a lot, and we are prepared to kind of talk about any questions you might have, and certainly we're going to share the PowerPoints that everyone has access to that, and this is being recorded. What's your question? And then, the question is about how are we documenting the visit, and we basically use in PNC a regular individual session note, and that's been attached to a different appointment type. I created a separate appointment type, a single session, that gathers a lot of the same information that our basic intake or our on-call intake has. So we have a bulk of information that the students filled out, both with the pre-test, the CCAPS, and our client information form. But then because the intake template, the paperwork is long and extensive and very symptom focused, we have attached automatically with the single session on the PNC schedule. It's just an individual session that gives maximum freedom to the clinician who's conducting the single session to write what they need to write when it comes to what occurred, what the interventions and recommendations are like, and what the plan is moving forward. And then we have the referral button right there to go.
And one of the things that we do include in that documentation is to list all of the interventions so that if the student does return, we can see what we recommended and we can follow up on some of that.
And by the way, if you are someone that wants to implement this and you need some of the PNC assistance and some of the nuts and bolts, I'm happy to have an offline dialogue about that at a later time. There was another question, Jerry. Okay. Mike, any other questions around the room? Impressions? Yes.
Do you ever have clients say that they don't want you to consult with other people?
I haven't had that happen at CAPS, but I've had that happen, over the years, where it's like, well, if someone's coming in, maybe paranoid, or if they've come in with a bad experience of
The
someone leaving the
question
room.
is about, have you ever had someone say they don't want you to go consult with someone else?
And in that instance, you just do the session and then do the all pieces without that.
Yeah, it's totally doable, but yeah, it's very rare that would happen.
I think that Alex would probably go with, or what I would recommend is asking if it's okay if I consult in front of you on the phone, or if you'd like the consultant to come in. Give a few different options, but what is in the way becomes the way, so maybe there's a conversation in that they're not wanting, or maybe it's just they're perhaps someone that wants the privacy and that's not alarming at all, it's just about the privacy, and that could be okay. Yes.
So it sounds like the student has a single session, they are now a client of CAPS, correct?
And when you think about the legality of having a treatment relationship, this is a treatment modality, and so they are a client.
So if they reach back and wanting additional services, is that single session therapist to the therapist, or how is it funneled back into the system if they come back again?
That's a great question. We're working out these details. We are not assigning people who have done this single session. This is not their primary student, so we're not assigning these cases to that person. In my position and my clinical coordinator team, when someone has had, the few times it's happened, they've had a single session and they're coming back in, we initially just do another consultation round. If I get it by email or phone, I'll field that one myself or pass it off to one of the clinical coordinators, and they'll field that, and we'll decide what to do with that case on a case-by-case basis. But out of doing 90 and only 4 have bounced back, that's manageable when you come in. Nancy?
I'm aware that some centers are doing a single session prior to having a brief screen or brief assessment first. I'm curious, Allison, if you've had experience working in those environments where that screening has not happened, and
Right.
how you've experienced UCSB where you are doing that.
Yeah.
The question is, what's it like to do a single session when there isn't the brief screen in front? And of course, we're talking about a system where I've really prioritized making sure the brief assessment's happening. Alex, do you want to speak to?
Yeah, so at the community center, it was walk-in, single session, so there was no screener. They just came in and filled out the paperwork. And what we did, though, we had a pretty robust consulting team. We always had at least 7 people available, and then we would alternate between viewing rooms and different things. So we would go back with that paperwork, and there would be a team facilitator that would review the paperwork, and then everyone would kind of do a quick pre-consult and then assign whatever therapist that might be the best fit for the presenting concerns. So that's how we did it, just on an ongoing rotation. It ended up just being first come, first serve. And there were rare cases when we'd have to send someone away, and then as long as we'd still assess the risk, but we'd say the wait is a couple hours, so you might want to come back this afternoon or something. But I love the VA. It is so much nicer to have it already kind of filtered.
The brief assessment, the BA.
Sorry, yeah. So it is nice that it's already been explained, they've opted in, they want to be there, they're excited that they could get an appointment, and it's just really, I think that's why we're having such good feedback and outcomes.
Something about the prep work and the intentionality, I think, lends itself to positive feedback. But really good utilization of the service. So. Other questions? Yes.
I'm not sure if you've already mentioned this, but can you just explain how you differentiate between an urgent drop-in appointment and assigning someone to a single session?
The question is about differentiating between the urgent drop-in and the single session. And I think that's why, with how busy our clinic is and how many different students are walking in, and how I want to really not have a one-size-fits-all system, we run everyone through an initial consultation. And that seems to answer the question of, is this a good group referral? Is this a good individual? In our initial appointments, that initial consultation, if it's urgent, if this is someone that's not known to us and it's a crisis, our brief assessment is as long as it needs to be. Sometimes they're 10 minutes for a quick referral out of the building. They got private insurance, they want weekly, long-term, they got a car, bye-bye. But for that urgent student, and especially the one that comes in and it's all tears and affect, and you can't even get anything substantive, and they didn't have the wherewithal to fill out the paperwork, well, you're in a crisis session. And so our folks are sort of prepared for that, such that we adjust our schedule accordingly. So it emerges as the clinical picture emerges. So.
Kind of a follow-up to that, just in terms of risk management perspective, it seems like you're wanting to invite students to a single session or higher acuity, and then by the same token, you're also suddenly discouraging them from more sessions. So how do you get around that?
Good question. The question is about how do we balance this with, okay, someone who's a little bit more higher acuity, and then there's this not so subtle, if you're me, not wanting to say, yeah, single session now and maybe another one later. We just don't mention the other one later, but it's a single session now. It's an intentional session now. And when we see that intensity, when we see the need, it's up to the clinician, and we're out of time here, but very much it's up to the clinician who's doing the work to make that clinical judgment. We're not hard and fast on our rules, and the system is set up so it is organic. We're out of time now. Do you have a final comment?
I just want to say, it can also be a bridge for those students. You can do the single session, the referral is to ongoing therapy. We've done that a lot, but not returning to single session, that's referral to ongoing. So.
If you have individual questions, we'll stick around for a minute out front, but thank you all for being here.